difficult is she's not comfortable here. Adding what I assume is a discomfort of a treatment procedure seems harsh. Like it seems difficult to manage, right? Like if this were something where we were more comfortable at home, she could come in and do that. That seems more approachable to consider. It's hard to think, like, what is the kind of discomfort associated with the ECT?
Yeah, so I'll kind of talk you guys like through like start to finish, like what the ECT procedure is like. So the night before ECT, we ask that patients don't have anything to eat or drink after midnight, and I'll talk with you about that in just a minute after my spiel. Here at Salem Hospital, ECT happens really early in the morning. The nurses would probably, or you would, get van up really early in the morning around like 6 or 6:30. And here in the hospital, the IV team will usually come and put an IV in because that's how she receives the anesthetic medication is through the IV. Then the nurses transport her to the PACU. You don't need to remember this, it stands for the post-anesthesia care unit. And that's where we do ECT. It's connected to this hospital, just on the medical side of the hospital. And then over there, you meet with the PACU nurses, the anesthesia team, and psychiatry. And you're just like on a stretcher. Then we put a lot of monitoring leads on the patient, and I think out of everything, that's maybe the most anxiety provoking is just the amount of wires that we have on patients. And I try to remind folks like all the wires are just like a bunch of different ways that we monitor everything. So there's actually 2 different telemetry leads so that we can monitor her heart. There's EEG leads so that we can monitor the seizure in her brain. There's EMG leads, which monitor movement during the procedure. We monitor blood pressure, we monitor oxygen rate. So it's a ton of wires. So I like to prepare people about that ahead of time. And it looks scarier than it really is. It's just like us, being extra careful to monitor things. And then basically we'll kind of meet with Van, we'll just chat with her briefly. And she gets usually 2 medications that we use during ECT. The first is usually methotrexate, also called Brevitol, and that is the anesthetic medication to put Van to sleep. And that's all Van really, everything after that she wouldn't be aware of until after she wakes up. The second medication that we give is a muscle relaxant called Brevitol. And we'll put a blood pressure cuff on her leg so that after she gets the anesthesia medicine, but before she gets the Brevitol, we cut off circulation temporarily to the foot so that the muscle relaxant circulates in the whole body except for the foot. So that the only place where we see a motor seizure, ideally, is in the foot. So if you've ever seen like out in the community or like on TV or something, like people having seizures, there's a lot of movement. That's how we mitigate that, is by giving them a muscle relaxant. And it's very short acting. And then after that, anesthesia will put a bite block in for the patient because when she gets the ECT stimulus, people will bite down. So that's just to protect her teeth, make her jaw more comfortable. And then after that, we give the ECT stimulus. Ideally, she has like no motor movement whatsoever. We just see the motor seizure in the foot. We're able to monitor the EEG seizure in the brain. Anesthesia watches blood pressure, heart rate, oxygen rate, all of that. And then we want the seizure.
Medical alert, code stroke, adult emergency triage. Medical alert, code stroke, adult emergency room triage. Medical alert, code stroke, adult emergency room triage.
A therapeutic seizure in the brain is 15 seconds or longer. If the seizure went on close to the 2-minute mark, we would give her another medicine to stop the seizure. And then the patient wakes up. We kind of, assess them again. They may be a little bit confused, but we're going to just make